Honorable Chairperson, respected panelists, and dear learned audience, Assalamu alaikum and a very good afternoon. I'm Dr. Abeeda Tasnim Reza, Associate Consultant, Clinical and Interventional Cardiology, Evercare Hospital, Dhaka. Welcome you all in my presentation. And the title of my presentation is Bifurcation PCI, Single Stent or Double Stent. Let us begin with the case summary. A 65-year-old normotensive diabetic lady presented to us with a positive family history with the chief complaints of chest discomfort and heaviness for 2 days. And outside she was diagnosed as a case of acute anteroseptal myocardial infarction 2 days back. Her physical examinations, the vitals are within normal limit with no cardiovascular significant findings. The ECG showed there were Q waves from V1 to V3 with STG changes and inferolateral ischemia. She had regional wall motion abnormality with mildly reduced LV ejection fraction of about 45 to 50%. Her troponin was elevated. So she went on with a coronary angiogram, and the coronary angiogram showed there is significant lesion in the proximal right coronary artery, and her left system showed that there is significant ostial stenosis of LAD. There is also a distal segment left main disease with, we can see that the proximal to mid LAD there is also a subtotal occlusion, and also there is 50 to 60% stenosis in the ostial LCX. So we calculated the patient's syntax score and it came out approximately 30. And the bifurcation lesion, the Medina classification was 111. So what should be the next step? So is it cabbage or multivessel PCI? And we gave the patient the two options, and she agreed to do the multivessel PCI. She did not want to go through the CABG. So we went through the right femoral root. First of all, we tackled the right coronary artery. It was wired and pre-dilated, followed by a deployment of 3 by 38 millimeter drug-eluting stents. Post-dilatation was done with NC balloon, 3.5 by 10 millimeter. And this is the final scene of the right coronary system. So next, what should be the bifurcation strategy in this case, in case of left coronary system? As we all know, according to the bifurcation treatment strategy, if there is less likelihood of side branch occlusion, it is still the provisional single stent strategy that should be opted. And if there is any side branch compromise during provisional stenting, then depending on the side branch angulation, we do the bailout strategy. So the meta-analysis of 9 RCTs have shown that, and according to the European Bifurcation Club recommendation, the provisional strategy is still superior to the two-stent strategy. So in this patient, we opted the provisional single stent strategy. So guide catheter was engaged in the left coronary artery, and we can clearly see the lesions here. First of all, the LCX was wired by a floppy wire. LAD wiring was done by a floppy wire by microcatheter support. So following wiring, there was sequential pre-dilatation was done first with a 1.25 by 10 millimeter and 2 by 20 millimeter balloons successively. First of all, a 2.5 by 28 millimeter drug-eluting stent was placed from proximal to mid LAD at 16 ATM, followed by a 3.5 by 23 millimeter drug-eluting stent was deployed from left main to proximal LAD, covering the distal stent at 16 ATM. So it shows the stent deployment. Following stent deployment, this was the scene that was taken, but suddenly the patient developed chest pain, and we could see in the ECG monitor that there was ST elevation with hypotension. So what could be the cause? And as we took the CNA, we saw that the ostial LCX is pinched significantly. So now what to do? So obviously, the second, that LCX need to be stented. So we went for stenting of the LCX. So it was rewired by the LED wire, and we ballooned the LCX with 2.5 by 10 millimeter balloon at 12 ATM. LCX is stented with a 3.5 by 12 millimeter drug-eluting stent at 16 ATM. LED balloon was kept and it was dilated, followed by LCX rewiring. Kissing balloon inflation was done by 3.5 by 12 and 4 by 10 millimeter at 12 ATM in LCX and LED respectively. Proximal optimization was done by 4 by 10 millimeter NC balloon at 14 ATM. So this is the scene after the proximal optimization. So we went out to do an IVUS study of both LED and LCX. This is the IVUS run, this showing that there is, the left side is the LED and the right side is the LCX. There is a good stent apposition. There is no dissection and good expansion of the stents. So these are the final scenes showing good T-metry flow with no reflow phenomenon or no slow flow. So what is the take-home message in this case? Decision regarding single versus double stent strategy should be individualized based on lesion characteristics. If side branch is compromised, prompt decision to bailout strategy is mandatory. IVUS-guided bifurcation PCI should be used whenever possible, and proper planning is the key to a satisfactory result. So with this, I'd like to acknowledge Professor Shahabuddin Talukdar Sir, Senior Consultant, Evercare Hospital, Dhaka, who was the primary operator of this case, and I'm really grateful to him to give me this case to present. So thank you all. Thank you for your patient hearing.